Thank you, sir. Good evening, everyone. I hope you all are up with us. Everyone is there? Mentally? Okay, thank you for that kind introduction, Dr. Nagarjuna. It's second time I'm coming to Hyderabad with Yashoda Group, and it's always a learning experience when you come back. You take something new, even the newer technologies, and probably in oncology we'll find some indication for it, for sure. So I have privilege of working at 3 different institutes, and I'm taking my experience from Tata on staging of and restaging of EBUS in lung cancer. Most of the things are dealt in bits and pieces in previous talks. In this talk, we will go through why we need lung cancer staging, and for that we need to understand certain basics of lung cancer management. We'll go through core concepts of nodal staging, and as time permits, we'll go through a few case discussions. I'm sure we all know this TNM classification, and I'm not going to go in details of that. But if you look at the 4 stages of lung cancer, the early stage has significant survival compared to that of dismal survival for the stage 4 and stage 4A or B. We are more and more focused on early detection of lung cancer. So many screening trials have been launched. But early detection, as it improves the survival, your accurate staging will definitely avoid unnecessary thoracotomies. If your patient belongs to an early stage, definitely you would look for a surgical management. Otherwise, definitive therapy will be offered to this patient in terms of radiation or chemo. Also in India, where tuberculosis mimics everything, the nodes which are lighting off on PET scan, all that lights up on PET is not malignancy. So in malignancy, there's 5 times higher incidence of tuberculosis, especially with cancer chemotherapy. So if your patient is on treatment and you're following that patient post-chemotherapy, the node becomes necrotic, it lights up on PET scan, you think there is a disease recurrence, but actually turns out tuberculosis. Hence, sampling those nodes becomes important. As well as complex clinical diseases. When you work at high volume center, you start seeing synchronous primary lung cancer as well as head and neck cancer, lung cancer with gastric cancer. In that situation, that mediastinal node will actually define stage for any of this cancer. If it is head and neck and mediastinal node comes positive, it is N3 and the patient becomes non-operable from the head and neck point of view. That's why we need to sample these mediastinal lymph nodes thoroughly. I'll try to simplify the lung cancer management. Usually, the lung cancer is divided into 3 parts: early localized disease, which is resectable, loco-regionally advanced unresectable, and metastatic disease. In metastatic disease, that is stage 4A and B, you have palliative systemic therapy. While early stage means what? Any stage 3A and less than that, obviously stage is early stage lung cancer. 3B and 3C, anything more than 3A is a loco-regionally advanced disease. So you look at N0, N2 defines early localized disease, while N3 defines the loco-regional. So the node is going to dictate the therapy in terms of lung cancer management. If you have less than N2 nodes, either N1 nodes positive or no nodes in the mediastinum, you have curative surgical option. If you have N3 nodes, the patient will be a definitive CTRT candidate. If you have N2 nodes, and this is a gray area where a lot of research been going on, that if you have a single station N2, if you can give them these patients chemotherapy and see whether they can come for the curative surgical intent or not. In terms of multi-station, it means you have more than 1 node positive on N2, that is a mediastinal site, either superior or inferior mediastinal, or you have a bulky node. If your node is more than 2.5 centimeter, it will behave like a mass, and these patients become non-operable. They don't do well after surgery in terms of survival, and hence definitive chemotherapy or immunotherapy can be offered to this patient. We have seen this N3, N2. I'll just briefly say anything above the clavicle is N3. Anything on the side of the tumor, from single digit 2 to 9 is N2. Subcarinal node is always N2. Whether the tumor is on the right side or left side, it is always N2. The nodes which are double digit nodes from 10 to 14 on the same side of tumor are N1. Anything on the opposite side is N3 node. The commonest investigation available for lung cancer management are like you will do a CCT or a PET scan for your patient, do MRI brain to look for metastasis. It will tell you about the T and M for definitely tumor size as well as metastatic site. But for nodes, it will tell you that there are nodes and they are lighting up on the scan. Suppose if you have a supraclavicular lymph node prominent, you will just go for a supraclavicular lymph node biopsy for diagnosis, as well as it will tell you stage, that is stage 3. N3. So, but when the mediastinal nodes are dominant in a particular patient, you need to sample them because the ultimate truth lies into the tissue diagnosis. No matter you use tissue harmonic imaging, no matter you use elastography, tissue is the truth. So what we need is the EBUS or EUS, which is in the hands of pulmonologists, while for invasive staging, you have mediastinoscopy and VATS, which is done by our surgeons. Sorry, this slide is not displayed well. Okay, let's move to next. This is a small question for you, and we'll quickly go through this in interest of time. So mediastinal staging is required in all of the following except, and it has been dealt in two previous talks, and I want 100% answer on this, that peripheral tumor less than 3 centimeter with ipsilateral hilar node more than 1 centimeter, any centrally located tumor, peripheral tumor more than 3 centimeter, radiologically normal mediastinum. That is, there are no nodes or node is less than 1 centimeter. Peripheral tumor less than 3 centimeter with radiologically negative mediastinum. You have 30 seconds to answer this question. Just move. Okay. So I'll tell you the answer. Okay, so it will be revealed then. Okay. Anyways, so if you go back to the basics, in 2013, ACCP came with the third edition of lung cancer treatment. And according to that, it is radiographic classification of lung cancer. There are 4 categories. A group is mediastinal infiltration. The tumor is located near the mediastinum. It has infiltrated N2, N3 everywhere, or major vessels as well. The second category is the discrete N2. The nodes are different from the mass. They are definitely separate from the mass, but they are everywhere. Centrally located tumor, and if you have a right hilar node, as it is shown in this figure, in this picture, you have only right hilar node, no other node is there, and you have a peripheral located tumor, and you have few mediastinal nodes. So in these 4 groups, what is important, what defines the treatment is N0 or N3. If you're N3, no surgery. So the prevalence of N2, N3 disease in a group A, where the mediastinal infiltration is there, is 100%. You don't need staging for this patient. Those who have discrete mediastinal nodes, that is group B, there is an incidence is almost 60%, and they qualify for staging. Centrally located tumor N1, the occult metastasis. After surgery, you may find that the N2 node is prominent in 20 to 25% cases. It will turn positive. So EBUS staging is necessary. For peripheral located, PET negative, mediastinum negative, you don't have to do staging because the incidence of N2 is just 5 to 10, which can be dealt with adjuvant therapy. If the PET is positive, please biopsy those nodes as well, irrespective of the tumor size or location. I think the quiz has already been dealt. So the question is repeated for you. Mediastinal staging is required in all of the following. The answer, okay. Excellent. So you are thorough with your concepts after this talk, and I'm sure you'll be able to do EBUS successfully. So to summarize, where nodal staging is required, when you want to, your patient is candidate for surgery or candidate for radiation therapy, and this N3 node, if comes positive, your radiation portal changes. If your N3 is negative, your radiation portal can be concise towards the mediastinum, so you save the great vessels, the heart, from radiation. In terms of oligometastatic disease, it means you have a lung cancer, you have mediastinal nodes, and there is some organ, like adrenal or brain, there is a single metastasis or less than 3 metastasis. That's the oligometastatic disease, and we'll see a case about it. Nodal staging is not required. You know the first answer. If you always palpate supraclavian lymph node in your patient, if it is positive, no question of further staging. It comes as N3. Your nodal involvement is there, or polymetastatic. Everywhere there is tumor uptake, where there is uptake in spine, there is uptake in liver, they become non-operable. So staging is not required. There are 4-5 rules we follow in nodal staging. Is that you start from N3, N2, N1. That is highest possible node on contralateral side, and then you come towards ipsilateral side. Minimum 3 passes are necessary, and 3 nodes should be done. That is station 7, 4R, and 4L. Must. Mediastinoscopy will give access to this minimum. EBUS will give access to everything, but minimum 3 nodes should be sampled. Sample all FDG-IVD nodes irrespective of their size, and if your primary tumor is PET negative, that is usually happens with mucinous adenocarcinoma, and your nodes may turn out negative in that situation. So don't neglect those nodes. You have to biopsy those nodes as well. Regarding the short axis N size, ACCP recommends 1 centimeter cutoff. The Medias trial, which has been published 1 month back, recommends 8 millimeter cutoff. Many papers, including the pioneer from Ramipota, 5 millimeter is cutoff is been used, and we use 5 millimeter cutoff in the lymph node size to define whether we need to do a sampling for them or not. Minimum 3 passes. Whether to do a rows or not to do rows, it depends on availability, but it will definitely reduce your number of passes. If your first pass comes positive on N3, you will stop the procedure. So your time is saved in that. So that's how the rows is applicable in rapid in a lung cancer. Also, it shows if it shows granuloma, a coexisting TB can be considered, and or tumor granuloma can be considered, and you can send these samples for microbiology. So that's the benefit of having rows. The samples from the EBUS, even irrespective of the needle size, they are adequate for molecular analysis. So even a NGS can be run on this sample. For nodal access, we have endoscopic VATS and metastanoscopy. EBUS and EUS will give you access to all the nodes. If you have sufficient skills, you can access subaortic and paraortic nodes as well. VATS will give you access to all the nodes, but only on one side, not the contralateral nodes. Hence, we look at the EBUS and EUS as primary modalities of staging of lung cancer rather than VATS or metastanoscopy. Anterior metastanoscopy has special role because station 5 and 6 are blind spots for EBUS. EUS guided also, it may become difficult because you have to traverse blood vessels sometime. Hence, you can look at anterior metastanoscopy, special situations like station 5 and 6. We have seen the PET sensitivity specificity, which has been less than 80%, less than 70%. Hence, you need a tissue diagnosis. Tissue diagnosis by EBUS and metastanoscopy, when it is compared, EBUS always has a superior hand in terms of sensitivity specificity. When you combine EBUS and EUS, you get access to almost 100% of the mediastinum, 90% sensitivity, compared to that of 79% in terms of metastanoscopy. This was our TMH data presented in ERS. I'll not go through details of that, but we compared the EBUS with metastanoscopy with surgical sampling, and the sensitivity comes up to 94% in 1 centimeter and more size nodes, which is lesser for the smaller size nodes. So we know that EBUS outpatient procedure, minimum sedation, multiple node sample, including the adrenal sampling, sensitivity is almost 94%, least complication, and there are no obvious contraindications to do a EBUS in a staging patient, who in a stable patient who will be a candidate for surgery or definitive therapy. Compared to that of metastanoscopy, it has some disadvantage. The advantage is that in metastanoscopy, sometimes a skilled surgeon will be able to clear the node. They will not only biopsy, they will clear the node, especially when you are dealing with station 5, 6 or 4L, they do extended metastanoscopy and they clear the node, which becomes difficult for them to access it during the VATS surgery. Putting it all together, if you look at the diagnostic algorithm, Dr. Kedar has already dealt with this. If your PET, irrespective of the CT or PET imaging, if your PET is negative, peripheral located, N0 node, no nodes less than 3 centimeter, you can go directly for surgery. Those who have central tumor, adenocarcinoma more than 3 centimeter, and you have a hilar node, where there is possibility of 25% you will get a N2 node. In that situation, you have to do tissue sampling with EBUS or EUS or metastanoscopy, whatever it's accessible to you. If the nodes are negative, do surgery. If the nodes are positive on the PET, if tissue confirmation is must with EBUS and EUS, if the lymph nodes are negative, your negative results of EBUS should be confirmed with metastanoscopy to improve the sensitivity and to reduce the unnecessary thoracotomies. So if the node is completely negative, prefer surgery. If it is positive, you can consider for CTRT or multimodality therapy. So recommendation to be taken from today is image your patient with CCT with upper abdominal cuts till adrenal and liver. If possible, PET-CT is preferred. In pathological staging, first staging should be done with EBUS and EUS, and the false negative results. To avoid false negative results, you can do metastanoscopy, a systematic mediastinal lymph node sampling during surgery to improve the sensitivity and reduce unnecessary thoracotomies. And last month only this paper has come, which has mentioned that this was an ongoing trial from 5 years, and it has, I'll just conclude it, that it mentions that metastanoscopy can be omitted in patients with resectable non-small cell lung cancer and an indication for mediastinal staging, especially when you are EBUS negative nodes. So we may expect some change in guidelines this year or next year, and only EBUS and US will take a central role in mediastinal staging. So whatever we have learned so far, let's put it into this practical application in these cases. The case of a 52-year male with cough hemoptysis, no suprachiasmatic lymph node, good effort tolerance. His CT scan, you can see there is a hilar mass. There are multiple mediastinal nodes. The mass is located below the into the lower lobe only. PFT is adequate for even for pneumonectomy. You look at the PET scan, multiple nodes are lighting up, and there is a contralateral hilar node as well. So the concept is that when there is a right-sided mass, you look at 4L and 11L in this patient, which are N3, then you go to N2, that is 4R and 7, and then you target the N1 nodes. So systematically, N3 followed by N2 have been sampled. They all turn out to be reactive. You go to the N1 node, and it turns out to be positive in this patient. You all know the endobronchial landmarks. You all know the ultrasound anatomy. I'm not going to go in details of that. But whether we need to sample N1 nodes every time or not. So if the patient is surgical candidate, the node will be removed during the surgery. So N1 node is not always necessary. It is necessary to prognosticate that this patient had N1. Subsequently, if it turns out to be N2, you can compare quality control on your EBUS sample, as well as it will tell you about the prognostication, but it is unlikely change the management. This patient is qualifies for surgery, will go for surgery. If the patient comes for definitive CTRT, you will be, irrespective of N1 positivity, you will be able to take this patient for treatment. Only advantage is that suppose you have inadequate material and the oncologist says, I want more material, then you sample the N1 node, which will be adequate even for NGS. So this patient had T2 mass, that is more than 3 centimeter, less than 5 centimeter, extending to right bronchial centimeters, not involving the canina. So surgery is an option for this patient. The metastatic workup in terms of PET and MRI is negative. Your nodes are dictating the treatment in this patient. The N3 and N2 are negative. So N1 comes positive. This patient is stage 2B. Our negative results have been verified with mediastinoscopy. The 4R and 4L and 7 turns out to be reactive and frozen. In my institute, what we do is, if the EBUS is negative, the patient is taken for mediastinoscopy. In the same setting, the mediastinoscopy comes negative. On the same day, same anesthesia, patient undergoes lobectomy or pneumectomy, whatever procedure he can qualify for. So you can see from EBUS, the clinical stage initially was T2 and 3, that is 3B, non-operable, only definitive CTRT. Post EBUS, it turns out to be 2B. And in pathology, when there is final verdict from pathologist comes that N1 is positive, N2 is N0, N2 is negative, your stage, your sensitivity of the EBUS, you can see, is almost 100% in this patient. Regarding the radiation therapy, this patient of 69 years, multiple comorbidities, has a weight loss, only undergoing evaluation for knee replacement, and his CT scan shows there is a right upper lobe mass. There are mediastinal nodes. You can see that node is enlarged even on right hilum. So this is peripheral located less than 3 centimeter, but the node is positive on radiological on the radiology. So what should be done? Patient should be subjected to staging. So this is a clinically T1, N1, M0. And suppose the mediastinal lymph node comes positive and this patient becomes medically operable, then you go for surgery. It means patient is fit for surgery, patient goes for surgery. If the nodes come positive and multi-station N2 comes positive, no question of surgery, definitive CTRT. If in this patient the nodes came negative, but patient was medically inoperable in terms of multiple comorbidities, his age, this patient was subjected to SBRT. SBRT is a stereotactic brachyradiation therapy. It gives comparable result to that of the lobectomies, segmentomy, not the lobectomy. Sublobar resection and SBRT has comparable results. So this patient was actually would have been subjected to systemic therapy, but because of your nodes are negative, because the size is less, it was subjected to SBRT. Now coming to oligometastatic disease, like this case of 58-year male who had right lower lobe mass, mediastinal nodes positive. You can see in abdominal scan there is a lighting up on the right side above the kidney. That's the right adrenal. So what should be done in this patient? Would you consider this patient as metastatic disease and just send it to the oncologist, you direct the treatment with chemotherapy? Or would you biopsy that adrenal? Would you biopsy the nodes? What should be done next? So even if it is metastatic disease, adrenal lesions or any lesion which is possible to be targeted with a definitive therapy should be biopsied. And what turns out, adrenal turns out to be adenoma, not adenocarcinoma. So, and when this patient was subjected to EBUS, all nodes came negative. So it was thought to be a M1B disease when there is metastasis outside. But this patient turns out to be 2B disease, stage 1 or stage 2. And this patient was subjected to surgery. But suppose the adrenal would have come positive in this situation, what we'll do? If your primary tumor is resectable, that is T1 and T3, if your nodes are negative, it means this patient becomes a candidate for surgery. In that situation, you can deal with these two different locations of metastasis separately with a definitive therapy. Like you do a surgery for lung as well as the adrenal, or you address these both situations with radiation therapy, definitive radiation therapy. So you see that I would have assumed that these nodes are positive on PET scan, let's take it as metastasis and go for surgery. The 5-year survival, go for the chemotherapy, 5-year survival will be far less than what we would have offered for this patient. It's like an interesting case of a bilateral lung cancer. You look at the right upper lobe and left lower lobe, there is a PET avid mass. Look at the left avidity, it is less than that of the right. There are mediastinum is completely negative. You don't expect this into the metastatic disease. Suppose you have nodule on the opposite side, you expect that the node will be enlarged. The dissemination will not happen without that lymphatic or hematogenous involvement. So this patient had bilateral lesion and there is nodes are negative on the PET. The right upper lobe lesion was biopsy, CT guided biopsy, adenocarcinoma. Left lower lobe lesion was relatively PET avidity less than that of this primary site. The PET CT was negative. This patient was referred to us for further management. We went ahead with the radial EBUS. We biopsied this. It turns out to be adenocarcinoma. Simultaneously, we did EBUS staging. Though the nodes were not seen on the PET, we did the EBUS staging. All nodes were less than 5 centimeter except station 7. We had a good central hilar sign with no necrosis. Turns out to be reactive. This is a case of a synchronous primary lung cancer. The concept of multiple primary lung cancers is evolving now. You have a lung cancer on both sides. The PET is negative. The mediastinum is negative. There is no metastasis elsewhere. This patient becomes candidate for sequential stage resection if the patient's lung functions permit. So you can see, we would have assumed that there is a bilateral lesion. Let's not go ahead. Let's do this patient with a chemotherapy. But this patient was offered reasonable chance of survival with VAT stage resection. Coming to the single slide, just few words on restaging EBUS. Restaging is done when you are dealing with a single station N1, N2 disease. Multi-station N2 goes for radiation therapy, but single station we look for whether they respond to the chemotherapy and to see whether they can benefit from surgery. So if you do NACT, neoadjuvant chemo, before the surgery, do a treatment, that is neoadjuvant treatment. So NACT or RT, it creates an inflammation in the airway. It creates a lot of fibrosis in the airway. So it becomes difficult to differentiate metastasis, fibrosis, and on a normal tissue architecture as well in the nodes. Hence, EBUS and US during the staging take more time. Restaging take more and more time. It is operator dependent. If you have experience enough doing the staging EBUS, you'll be able to target them. Otherwise, there is a lot of confusion. The margins are not well defined. They become fuzzy. They get integrated with the vascular anatomy, and you'll not be able to differentiate those nodes. Since the sensitivity of EBUS TBNA, USB FNA is dismal, very less compared to that of primary staging EBUS or EUS. Mediastinoscopy also has variable sensitivity. Because the mediastinum is fibrosed, you cannot put your mediastinoscope. It's like a laryngoscope. You put a laryngoscope inside a hard structure or fibrous structure, you'll not be able to differentiate the nodal tissue from the fibrous tissue. Hence, that sensitivity is still less. Current guidelines recommend that you can do EBUS and EUS as a first restaging procedure, followed by mediastinoscopy to define the nodes are negative, and if the patient is planned for radical therapy. Let's see this case of a 66-year male who has a chest pain, left lower lobe mass. You can see that is PET avid, but mediastinum is very minimum. Only subcarinal node showed some avidity. We went ahead with staging EBUS in this patient. The subcarinal comes positive. So that becomes T2, but N2 disease. Single station N2 has come positive. This patient was subjected to NACT, but post NACT after 4 cycles, you see a PET image. There is a, I'm not sure why it is displaying like that, but there is a 4R node which was avid. So restaging EBUS was done in this patient. It turns out to be positive. Adenocarcinoma, this station which was 3A becomes 3C. And hence, this patient was subjected to CTRT. So, multidisciplinary team meetings, or you can use restaging procedures if at all the patient is subjected to NSCT. So, to summarize, use CCT, PET CT, upper abdominal cuts in initial imaging tool. Staging is critical as it dictates the therapy and as well as the outcome. Mediastinal lymph nodes must be staged by EBUS and EUS combined together to start from the highest stage possible. Identify less than N2 disease, because these patients should be fast tracked for surgery. If you wait for 2 months for this patient to subject for surgery, they may have upstaged. Mediastinoscopy should be done after EBUS TBNA negative cases who are planned for radical surgery, but guidelines may change this year. Restaging EBUS and US or mediastinoscopy, or you should go only by MDT decision, is an institutional practice, and maybe the future guidelines will throw more light on this. Thank you.